So thank you very much for the invite. My name is Rob Truby. I work as a researcher at the Centre for Trials Research. We're based in Cardiff. It's like an academic trials unit there. And I have a particular interest, along with some colleagues, in how to use routinely collected health data in trials and how to integrate those into trials. And so we've been, over the last few years, I guess, working on a series of kind of projects that are looking to build capacity among fellow trialists for using this type of data in trials. So there's a big appetite for it, but a bit of a capacity gap. And so we've been trying to address that gap. And I'm joined today by Amaka Tobigbo, who's going to talk a little bit at the end. Amaka joined us as part of our HDR UK Black Internship program last summer and did some work with us on some training. And she's back with us at the moment as part of her final year medical elective placement as well. So she's going to talk a little bit at the end about some of the work she's been doing with us. Okay, so just a very brief scene setting kind of slide, I guess. Clinical trials, which we're obviously very familiar with at the trials unit, kind of still the gold standard for evaluating interventions, whether they're drug interventions, devices, different ways of kind of treating people, but they're incredibly inefficient, to be perfectly honest with you as well. They are very, very expensive to run, millions of pounds to run kind of good clinical trials. They're very, very time consuming. So from the kind of inception through to the running of clinical trials, through to the reporting, can take several years. Often the kind of healthcare system that you're aiming to inform has kind of moved on considerably since then, or things have changed. So there's that kind of element to it. They're also they create a lot of burden. They're very kind of resource intensive for not just for researchers, but for NHS staff who are often kind of heavily involved in recruitment or collecting the data at site. And also for the people who take part in trials. Frankly, it's I don't know if anybody's taken part in a clinical trial, but it is an extremely burdensome experience, I think, for people. They often have to come back to clinic multiple times, fill in batteries of questionnaires, lots of kind of hands-on involvement. And I guess not unrelated to that, we have a kind of wider issue in trials around recruitment. So there's, on the one hand, we often have issues recruiting enough people for clinical trials, and that's one of the main reasons that clinical trials end early or don't kind of meet their objectives. It's just a failure to recruit enough people. But related to that, I guess, is this big inclusivity issue. We have a problem with who we recruit to trials. They're not often representative of the kind of wider population, or at least the population who we're targeting the trial at. So, of course, all of us who are interested in kind of routinely collected data and data-enabled trials sounds like a kind of an obvious answer to a lot of these problems. And this is kind of like a, the utopian vision for what trials might look like if all of this worked perfectly. Obviously, embedding kind of collect data that's already collected in healthcare systems into trials can help with cost and resource. It might help us recruit more effectively, target recruitment, but also do it more efficiently. In theory, it can help with data quality. Maybe this kind of data that's collected at source is more reliable. There is a range of outcomes that we can look at. So we're kind of restricted in trials to how many questionnaires people can really tolerate us throwing at them. Whereas obviously we can collect a range of data that's already being collected at source. We can look at linking with wider data sets. We can certainly retain people and follow them up much more efficiently if we can link to their healthcare data. We lose people very often in trials after a number of years because they simply drop out or don't answer questionnaires. And in theory, it gives us this kind of potential to broaden the research agenda. So there are lots of rare diseases or topic areas that there's just not quite enough funding or not quite enough demand to fund for trials. But if we use data-enabled approaches that are slightly more efficient, then we might be able to broaden the research agenda. So this is obviously the kind of best case scenario. These are all the things that we think data-enabled trials can do. But I guess most of us on this call, even if we are not involved in trials, will be familiar with some of the challenges of using this data in practice. So there's lots of the usual questions around data quality and missingness, timelines to access this type of data, governance hurdles. And you can imagine in a clinical trial setting, all of these are kind of exacerbated or sharpened a little bit. There's extra scrutiny, understandably, from sponsors and funders and regulators on data quality, precision, where that data's come from, data provenance. Even more kind of pressure on timelines. You might get funded for a couple of years to run a clinical trial, and you can't, once that funding runs out, then you can't wait for data access. And lots of kind of interactions with good clinical practice, GCP, and just trying to think about how you document consent and all of these extra additional things that are kind of particularly important in trials. So on the other hand, of course, trialists have lots of kind of expertise in delivering trials and specific skill sets, but they don't, outside of a couple of kind of specialist centres, they don't generally tend to have a lot of background or knowledge about how to access routine data and what's out there, how they navigate all of these challenges. So there's a kind of capacity gap that we've been trying to look at. And just to kind of reiterate that, so there's a colleague, you guys all know Fiona, who's worked a couple of years ago on this kind of Delphi exercise, just asking trialists about their kind of perceived challenges of accessing this type of data in trials. And I think the kind of headline is that there's a lot of interest in using routine data. People can recognize all these benefits, but they have lots and lots of questions about how to do it as well. There's just a kind of a reticence about data quality, about timelines, about regulations, about how to engage with the public. So if we're consenting people to access this data, how do we convince them that we're going to look after their data and this is a kind of a valid way for them to take part in a trial? And so that was kind of the backdrop. It was a couple of years ago that we did this study. I think in terms of the kind of statistics, we were looking at under 5% of UK trials have accessed routine data or have tried to access routine data a couple of years ago. I think a proportion of those, maybe half, actually end up accessing data. So even among those that do, many of them don't end up being able to get that data within the timeframe of their trial. So that was the kind of backdrop to this infrastructure funding that HDR UK put in place a couple of years ago. This program called Transforming Data for Trials, nice ambitiously named infrastructure funding, 5-year program that's kind of brings together lots of different groups from UCL, from Oxford, from Dundee, and from ourselves in Cardiff. And we've got a kind of mix of trial methodologists, data specialists, clinical specialists, etc., leading the program. And I think it's, as I say, it's funded for 5 years. We've had about 2 years of funding so far. And I've just kind of tried to illustrate on this slide a couple of the different areas. So I think it gives a kind of idea of the scale of the challenge, but also the kind of scale of the ambition of this big project. We've got all of these different kind of work streams being led by different teams. So on the one hand, on the first hand, we have this stakeholder forum, which is an attempt to bring together all of these groups, trialists, data owners and custodians, members of the public, funders, who obviously play a big part in all of this, and data regulators, to sit those groups down to understand their kind of constraints and their priorities and their experiences of trying to do these kind of data-enabled trials. We have also got colleagues who are developing quite a detailed route map. So this is kind of like a London Tube style kind of map of all the different parts of a clinical trial, the different stations, the complexities within that, and where within that we can integrate routine data and where we can and maybe can't integrate routine data. So that's kind of framing a lot of the work that we're doing. We also have some colleagues in Scotland developing case studies. So despite all of these challenges, there are plenty of very successful and kind of innovative data-enabled trials running now that have completed. Certainly over COVID, there was a kind of an explosion of these data-enabled trials. And so I think colleagues are trying to put together some case studies to show how some of those trials work, just to kind of highlight some of the success stories, maybe to understand what did and didn't work within some of those trials. And just share some insights, and I think maybe provide some kind of reassurance to funders that these types of trials can be done, they have been done, that some of these challenges are not insurmountable. We've also got this strand of training resources, and that's what we are leading on in Cardiff, and I'll touch on that in a second. And finally, some work around data utility. So this is quite a big topic, just to try and understand and maybe collate together some learning about what healthcare systems data has been used in clinical trials as trial outcomes or recruitment aids successfully, what data maybe isn't fit for purpose, at least currently, and trying to feed back some of that information to data providers as well. And around all of this, we have a kind of public advisory group that we put together at the beginning of the project of, I think it's just over 20 members of the public now. So we had quite a lot of interest to take part. We selected 20 people from across the UK, a range of kind of backgrounds and interests. And that group meets quarterly to kind of hold us accountable for what we're doing, but also they're kind of available to us as a sub in terms of like little subgroups. So when we put together training modules, for example, we can invite 4 or 5 of those members to have a kind of good couple of hours discussion about what we are proposing to do with the training module, what they think might need to be included. And we often have kind of discussions around public trust and EDI kind of angles, which is really, really helpful, actually. And they're a very nice group of people that kind of hold us accountable. So in Cardiff, as I say, we are leading on the training resource side of things. So for the last couple of years, we've been working with HDR UK, who now have their HDR UK Futures platform on their website. So I don't know if anybody has accessed this at all. It's kind of free to sign up, and it's usable by researchers, non-researchers. You don't have to be a researcher to access it. But it's they've now got it all organised very nicely on their new platform. So you can look at different kind of bite-sized videos individually, standalone videos, or some of them are arranged into kind of courses and learning pathways. So we've been working with them to develop a series of kind of training modules, so like thematic modules that we hope are addressing some of these challenges that people are experiencing as trialists. But there are also some videos we put together for members of the public who might want to be part of like a PPIE group for a trial that's using routine data, and some training coming down the line for kind of funders and regulators as well, just to give them a little bit of perspective on the challenges of running trials as well. So that's all available there now. We've got various courses that are up there I'll kind of touch on in a second. And some of it's kind of CPD, I can't think of the word, CPD accredited, so that people can kind of do that in their own time as well. So that's it's a nice little platform that we're working with there. So just to give a kind of flavour of some of the things that we have been looking at, Fiona and I actually presented to the UK Trial Managers Network a couple of weeks ago, and we did a webinar just on the kind of basics of using data in trials. And I think we had 150 people turned up to that, and they sent a lot of questions in advance. We had about 7, 8, 9 kind of pages of bullet points on just questions that people had about this. So there's a huge appetite among trialists for doing this, but also lots and lots of questions about how to do it properly. And one of the big things that they're interested in, as you can imagine, is can we use data that's in primary care, secondary care registries as clinical trial outcomes? So you can imagine that a lot of the things that are kind of trial endpoints or primary outcomes are, health measures that are probably in some way available in primary and secondary care data sets, even if it's a kind of composite. And so, for example, if people are running a trial where the outcome might be kind of cardiovascular events, some of those, if you're collecting that directly in a trial, there's a lot of processes. You might be combining different kind of medical notes, but also there's clinical adjudication. So you're asking NHS consultants to kind of adjudicate and to look over certain notes and to check whether they think something represents one of your trial events. It's an incredibly resource-intensive, expensive, time-consuming kind of way to collect data. And so I think people are really interested in, can we maybe supplement or perhaps in the long term replace some of these outcomes with things that we know are available in secondary care data or primary care data? And can we, even if we can't do that, can we collect some things in terms of follow-up? Can we follow people up? If we're running a drug trial, we might be interested in, you might only have time to follow people up for a couple of years afterwards, but can we link to their data and follow them up for 10, 15, 20 years later without having to, without all the burden being on them, etc. But there are lots of questions around all of this. As you can imagine, people a little bit reticent about which outcomes are actually fit for purpose, what data can be relied upon in NHS records. How are we going to kind of create some of these composite outcomes? How do we join together different bits of data from different data sets? How do we, if we're running a trial quite often in England, Wales, Scotland, how are we going to join together all of these data sets? And are the codes similar? Can we map them all across? Lots of kind of technical questions and technical challenges. And we're also collecting trial data alongside routine data. And how do we combine all of that? How do we integrate it? How do we analyze all that together? We can't just kind of hand that over to our statisticians or health economists and hope that they can kind of navigate their way through that. So we've put together over the last year or so various bits of training that try to address some of these questions. There's a module that Fiona's put together that's just a kind of intro to using health systems data that I think addresses some of the kind of basic stuff around, right, what data is actually out there, how do you access that, who controls that data, what does the pathway for accessing that data look like? Some more kind of technical stuff on how to join together trial and routine data in a TRE. Interested in synthetic data and how that's being made available. Can we use that while we're waiting for kind of the real data to develop codes and develop algorithms? And there's also data utility comparison studies. So these are kind of studies that people have run where they have collected both sets of data. So they might have collected all the trial data that they would normally collect, but they've also collected the equivalent HES data, for example, or CPRD data. And at the end of the trial, then they do a kind of retrospective look at how those two data sources compared. If they had only used HES data, would they have come to the same kind of trial level conclusions? How did that data match in terms of an individual level? How did it match at a kind of intervention versus control group level? And there are various studies that have been published. This training is really about how you do that and encouraging people to do it. But there are studies in the literature now where, especially for things like mortality data, you can imagine that type of data is perfectly reliable and very often matches or is more reliable than kind of self-reported data. And there are other areas where people have set out thinking that they could answer questions with kind of hospital data, but have found that actually some things are treated outside of hospital or are not reliably coded in the data. So we're kind of developing a bit of a library of what can and what can't be used, and hopefully feeding some of that back to data providers as well. The other area I think that people, trialists particularly, are very, very interested in how to use healthcare systems data is trial recruitment. So I said that trial recruitment is a major kind of challenge. Often in clinical trials, there is clearly the potential to use data that exists already to kind of guide some of this recruitment. And I think people recognize that they could be doing this a lot more efficiently. Obviously, at just that population level, if we're interested in doing a trial on, I don't know, people with sort of type 2 diabetes with certain comorbidities or certain medications, you can clearly kind of access population level data just to get a first idea of, is this going to be feasible, or if this is feasible, where are people kind of clustered or based, and how can we open sites that maximize our chances of recruiting people. But there's also this kind of next level then. So if we are looking at that kind of people with this certain condition, people who are taking certain medications, can we use, for example, CPRD data and identify those people directly with a combination of codes, and perhaps via their GP then invite those people directly to take part in the trial and say, look, we've noticed that you have this condition or set of conditions, we're interested in running a trial, and would you like to take part? So there's that kind of direct recruitment. There's a lot of information governance and consent and ethics issues around that, of course, but those are kind of things that CPRD, that SAIL, that NHS DigiTrials are offering now as kind of potential services for people. Again, lots of questions. How do we do some of this feasibility testing pre-funding? So CPRD, for example, charge money to do some of these services. If you haven't been funded for a trial yet, it's very difficult to kind of get that feasibility exercise done. People naturally asking, is this data reliable? If we're going to be sending direct invitation letters to people, how confident are we that the data we're using is actually accurate, is up to date, etc.? And who's missing from that data? And we'll come back and touch on that in a second. But obviously, not everybody is kind of coded properly in these data sets, and we need to be mindful of that as well. So again, we have started trying to put together some training on this kind of introductory level, but also a deep dive on how we can use health systems data to support trial recruitment, what services exist, how people have done this successfully, and what some of the kind of ethics around that is as well. Now, a lot of the focus that we've looked at so far is around kind of technical challenges of doing some of this work, but obviously there are kind of ethical and wider issues around data-enabled trials as well. And one of the things that we have certainly spent a lot of time thinking about as a group is public trust and public social license, essentially, for this type of work. So most of what we do in trials is consent-based, so it's informed consent that people clearly need to be comfortable with what we're proposing to link to. We're going to access your kind of primary care data or secondary care data. It's informed consent, so we need to be able to rely on public support and trust, and that is quite fragile in this area, understandably. I think people in general, there's kind of broad support for the idea of it, but there are a lot of caveats, and people do need a lot of reassurance about what you're going to do with their data, how you're going to keep it safe, how this is going to benefit them or the wider community, etc. So we have put a lot of emphasis on this. I think certainly within a trial, you need to understand what the concerns of your particular population are, and that's going to vary between trials naturally. I think you'll see kind of lots of published studies that people in general have high levels of trust in universities or the NHS, but that doesn't always hold, and not everybody does have trust in those institutions, and we kind of have to be mindful of that and appreciate the kind of context. We also have to put a lot of effort into developing participant-facing materials. So if you're going to write a kind of information sheet to explain to someone why you want to access their routine data, there are a whole load of things that we need to put in there for kind of GDPR reasons, which are not necessarily very digestible for members of the public and kind of look a little bit like information overload. But at the same time, we want to kind of address the questions that they might actually have. And we put quite a lot of thought into this through this training course that we developed last year. It's kind of a deep dive into what members of the public are actually concerned about in this area, how we can, as trialists, go about approaching that, how we can design good public-facing materials that are kind of layered so that the information people actually want to know is at the front, that there is more information then for people if they want it, that kind of meets what NHS England or SAIL are looking for in terms of their kind of GDPR compliance, but also doesn't just completely frazzle people with a 20-page information sheet that nobody is going to read and kind of instinctively will create a bit of distrust. So yeah, lots of thought that's gone into that. I think that's something that we're continuing to be very interested in. Lots of kind of public workshops. The public advisory group I mentioned are always kind of very interested in all these kind of public trust angles as well. I think there is a big risk that if we don't do this, we talked earlier about the kind of inclusivity angle, but if we move to data-enabled trials and there are people who don't trust researchers to access their data in that way, then you're going to create or going to kind of exacerbate some of those inequalities potentially or create new ones. So related to that is this kind of wider topic that I guess encompasses trust, but it's about kind of equity, diversity, inclusion. I started off by saying that data-enabled trials certainly have the potential, in inverted commas, to make trials more inclusive and diverse. You can imagine, if we're able to identify people directly from their health records, often when we recruit for trials, it's kind of based on a chance encounter of seeing a leaflet or your GP inviting you to take part in a trial. If we cut out that kind of that gatekeeping element, maybe we can be more inclusive, maybe we can be more direct. But our public advisory group are very, very keen to point out to us regularly, and I think this is a really valid point, that actually routine data, as we all know, reflects some of the gaps and the biases that exist in the system. There is a lot of evidence that ethnicity, gender, disability are not coded very well in routine data. They're missing, they're inconsistently recorded. There is ethnic bias in terms of who is successfully linked at data. So if we send a cohort of a couple of thousand people to NHS England, maybe 95% of those are able to link, and there is an ethnic bias in who doesn't link, because it's all based on kind of naming conventions, etc. We know there's kind of upstream, there's gender bias in how people's in medical diagnosis and recording, and of course, members of the public a little bit uncomfortable that if we switch to an approach where we're relying totally on kind of medical records and not patient-reported outcomes, that some of those biases are going to be exacerbated as well. And obviously, there are just people who don't access, there are groups of people who don't access healthcare as often, and they can essentially appear invisible in some of that data. So I'm going to pass over to Amaka in a second, who's been very interested in some of this and has been helping us kind of explore some of this. But I think, yeah, this is something we're really interested in kind of pursuing a little bit, just to kind of highlight the potential for this to help with inclusivity, but also the fact that we can't just assume that using data-enabled trials will be a kind of magic bullet for all of this. There's a lot of challenges as well in this kind of area. And so I'll pass over to Amaka, who's been kind of developing a few video resources in this area for us recently.
Hello, guys. Thank you again, Rob. So yeah, just to carry on for what Rob's saying, a brief introduction about myself. My name is Amaka. I'm currently a final year medical student at Cardiff Uni. Last year, I did a master's in public health at Bristol University. And alongside my studies, I co-founded an organisation called Communect, which is a community engagement agency that works to amplify the voices of underserved and under-resourced groups in health and care research. So when I first started working at TopCat, it was basically a great time because they were working on this module on equity insights and how to basically, bridge the gap between the underserved and those who have the resources available to them. And particularly, I was really interested in how I can amalgamate the work that I do with Communect to what TopCat were doing at the time. So briefly about Communect, again, what we do is that we will do participant recruitment for research and community organisation. We would do things like facilitating focus groups, workshops and discussions. And we also organise collaborative spaces between local community members and health stakeholders. So this allows us to reach a broad range of people, particularly in under-resourced groups. And we build those relationships with them from the offset so that we can connect them with health research. So we do a lot of grassroots stuff. We go to the communities a lot. We build long-lasting relationships with not just community members, but also community leaders and health stakeholders. As well as that, we act as stewards to these local communities to prevent things like parachutists. So a lot of community organisations and community members, I think they've had a lot of distrust in research groups and health boards and healthcare institutions, because a lot of the time they come into these communities for a short term, they implement either a project or they do a bit of research, they gather information and then they leave and they don't try to foster any long-term relationships or empower the people in these communities, help them to, have a bit more knowledge in research, have a bit more knowledge in trials, have a bit more knowledge in healthcare. They kind of just feel like used and abused. So we are able to act as stewards in this case because we're able to be the filter almost that connects them, community members, with people like yourselves and people who do trials and research. We've worked with the likes of the Welsh Government and Public Health Wales as well to engage with these local communities. We started in Cardiff, but we've gone beyond Cardiff now. So we've been doing a lot of stuff to do with policy and public health initiatives, and it's been really fun. That's me. So next, I'll be talking about, I guess, the HDR program. So last year, I applied for the Black Internship program at HDR, and I was matched to TopCat in Cardiff. And like I said, when I got there, I really wanted to try and amalgamate my experiences and everything I've done with my life in medicine, with Communect, to what TopCat were doing at the time. So I was able to produce a mini series of bite-sized videos exploring the concept of trust in the context of clinical trials, particularly the ones that use patients' health systems data. So I was able to also share tips in engaging with underserved groups in order to rebuild and maintain trust in routine data trials and ultimately to diversify trial participation. So an approach I touched on particularly was how to engage with underserved communities. And I think the best way to do this is through partnership work. So people who do trials or people who do, data collection or data management, I think we really need to look to a way to form partnerships with local organisations, community leaders, advocates, local groups, because these people already have an established presence in these communities. So one of the ways to do that would be either to go directly to these communities and engage, or to use people like myself at Communect to help, you know, kind of streamline that communication. So you could either use a community engagement specialist that's already there in the community, or go to the pillars in the community. Aside from that, we touched on the concept of trust in research. You know, again, the importance of building and maintaining trust in trials that use personal healthcare data. I think a lot of the time people don't necessarily mind using the data, but they don't want to be exploited. So a lot of it is kind of explaining what the data is going to be used for and why it's going to benefit them. So that's really important. You know, I feel like we shouldn't skimp out on that side of things just because these people are maybe not as educated or don't have English first language or are a bit, you know, marginalized in society. They still require all the same, you know, levels of explanation and things that you would give any other group. And then, so yeah, we looked at, you know, why trust might actually differ between individuals. So again, you know, these people may have felt that they've been exploited in the past. You know, we look at in history, a lot of, you know, ethnic minority people have been exploited in research. All of these things contribute to why people would not trust, you know, people who use health systems data or trials. And then finally, we looked at the impact on trials using health data. If this trust breaks down, you know, it definitely has a big impact on trials going forward. If the people that you're trying to use the information on don't trust you as an organization, don't trust you as researchers, then ultimately, again, you probably won't be able to use their data because they don't consent. But then that has huge ramifications to the outcomes of your research. So yeah, these are all things that we looked at in the videos last year. And ultimately, it was really fun. We were able to do a lot of filming. Rob was holding my hand through the whole thing. And we were able to produce something that is now on the platform. So next, I was going to talk about my elective for this year. So this year, I came back to HDR. I came back to TopCat to work with them on my medical elective. And this year, what we're looking to do is produce some bite-sized videos looking at why there is a need for inclusivity and diversity considerations in trials that use health systems data. So we're looking at issues particularly in the context of course, data-enabled trials. You know, we're touching on recruitment challenges, the impact of exclusion. So, for example, a large section of the population won't necessarily engage in, you know, health systems. So when we want to use health systems data, it may not fully capture a large proportion of the population in which we're trying to reach. So, you know, looking at how when people are excluding themselves from health systems, we then would therefore not be able to get their data. So therefore, again, the results will be skewed because a large subset of the population aren't captured in this in the data. And of course, again, those who then don't engage in these health systems, they often are the ones facing disproportionate health issues, poverty, health inequalities, all these other, you know, barriers to health that we touch on, you know, regularly. So, you know, ultimately, when we produce the results for the research, it again may not be suited for the people that we actually want to reach, who are the ones who don't engage in health systems. So it's kind of a knock-on effect in this regard. So, you know, there are various barriers that these people would face and experience. Again, we've touched on mistrust, you know, logistical issues, for example, like not being able to get to health systems, not being able to get to GP appointments, not being able to get to where this data we source these data from, you know, time off work, care and responsibilities. There may also be cultural and language barriers as well. People not really understanding why they need to attend their appointments, what the need for it is. Maybe they don't really understand the language that's being used when messages are communicated to them. And then things like digital exclusion as well, which is another whole subset of things that we can touch on. But yeah, so that's basically what I'm doing in this time around. And then I'm also working with Kim Moonery and assisting her in the scoping review on public and professionals' perspectives on inclusivity and diversity for trials that use routinely collected data. So again, touching on similar themes of inclusivity and diversity. A lot of trials, you know, don't really consider it. So we're kind of just doing a scoping review at the moment to look at what people are considering when it comes to underserved, under-resourced groups, and if they've even considered trying to close this gap in their groups. So yeah, that's it. Thank you.
Thank you, Mecca. And yeah, it's been really lovely to have Amaka with us actually, and kind of bring all of that experience to our team. And she's just been kind of sat in on some of the interviews. We're just about to take on another two interns as part of the Black Internship program this coming summer, and Amaka was able to kind of help us shortlist and interview those candidates and kind of reflect back some of her experiences. So that was lovely. And I think, yeah, we're really looking forward to working with those two students as well over the summer. So I think that's it for us today. I just wanted to say thanks and kind of give a nod to the wider group that are involved in all of this different training. And finally, just to say, I know there's, we kind of have this trials experience that we've just talked about, but I think a lot of what we're doing at the moment is just trying to get across a lot of the kind of health data science challenges and communicate that in a way that is kind of accessible to trials audiences. And I know a lot of people, including those on the call today, will have a lot of expertise in that kind of area, and we're always very, very keen to work with kind of subject matter experts and people to develop training in this area. As I say, I think there's a huge appetite among trialists for this kind of knowledge and information. And so we're hoping over the next couple of years that we can kind of keep putting that together. So thank you very much.
Thank you. That was really fantastic. I really, really enjoyed that. I want you to like sort of tell us if we do want to work, for example, with the Communect, how does somebody do that? How do they get in touch with you? Is there a link you can put there? And on the same way, if people want to start doing a trial, which uses routine data, are you suggesting they go on Futures and go through the research, go through your teaching? Do they get in touch with you? What would you be happy with if people are like, I'm so enthused, I want to get into this?
Yeah.
Where would you direct them?
I would say, yeah, so the HDR UK Futures, I'll try and find the link now. You do have to register. That's the only thing you have to do, but it's one page to kind of put your details in, and it's completely free. So if you type in HDR UK Futures, it will come up with that training platform. I think apart from just our work, there are actually loads and loads of really good videos on there about kind of health data in general. So I think the difference with ours is, thank you for Googling. Yeah, the difference with ours is kind of trials related. So if you type in trials, you'll get all of our videos, but there is a whole wealth of information on there about public involvement and engagement that I'm sure Jack, for instance, will be very interested in, a lot on kind of health diversity as well. So I think they've relaunched it recently, so they're gradually adding back content that was kind of in there previously. And certainly we'll be adding new videos over the next few months and years, and we can share that obviously with this group. We're about to do a bit of a promotional push. So up until now, we've had like a few 3 or 4 modules on there. Now that we've got a bit of a group of them, we're going to do a bit of a comms push, I think, and just let people know that that's out there. So I think there is, as I say, certainly in the trials community, there seems to be a massive interest in it, but just kind of, yeah, lots of, I don't know that the environment that we all work in is always like the most conducive to trying things out or being innovative, but I think people definitely kind of recognize some of the benefits.
And how do people get involved or like work with Communect? What would you advise?
Amaka?
Yes, so so if you wanted to work with Communect, you can definitely email us. So we have a website as well, communect.com, but we have an email address. I can put that into the chat. I don't know if that would be easiest.
Please. Yes, please.
Yeah, so we're currently working on a research at the moment with the Healthy Start scheme. I don't know if you guys know the Healthy Start scheme in the UK, yeah, but they are looking to recruit for focus groups mothers in Wales who are using it. So we're working on that at the moment. So we're doing a lot of recruitment at the moment in Cardiff and in Southwest as well. So it'll be really cool if like researchers get involved in that. But yeah, I can put my email in there. That would be cool. We also have a website.
As a group, are you interested in people who are putting in grants that may want to ask you to be part of a grant? Is that the type of thing?
Yeah, so we've worked in the past with people who are doing trials. So obviously from the offset, when they want to put their grant in, they have to consider, how they're going to engage, people who are underserved and things. So a lot of the time they've reached out to us and they've kind of hired us as consultants for the process of the trial. So yeah, that's I guess an idea of similar work we've done in the past. Yeah.
Brilliant. No, thanks. Does anybody have any questions or things they'd like to bring up? Any thoughts from people? So go ahead, Jack.
Not really a question, to be fair, but I just it was music to my ears, the stuff towards the end, especially Mako, with your work, and I definitely want to have a look at the training resources, because that's something we've been looking at as well, and although not in trials, obviously different context, and yeah, I might be bothering you in the near future just to chat a bit about your work, because yeah, this is something I'm really interested into.
Amazing, thank you.
No, that was a fantastic both talks, so thanks so much. It was really, really, really good.
Just to briefly on, we haven't worked directly with the Maccas, but we have worked with other kind of community engagement agencies on some other projects that we've been doing, and it's a massive opportunity, I think, for kind of researchers. We are not necessarily, some of us might be, but we are not specialists at kind of recruiting people and reaching out to communities that we are not familiar with, I think. And I think there's no kind of, it's a good thing to work with specialists in this area, like we would work with kind of graphics design specialists and specialists in other areas. We were kind of inundated for a synthetic data project that we were looking to do. We were kind of worried, could we get 40 people who wanted to talk about synthetic data? And I think we worked with this agency. We had over 200 applications from people. Just, yeah, it makes a huge difference. And it does genuinely kind of help us to reach people that we, I think, as academics wouldn't be very good at reaching.
Yeah, it does. A side question about the trials. So CPRD, it is feasible then for identifiable data in CPRD, or is it that I'm trying to see how it works? I can imagine in SAIL how this would work, where you might say these are the people who've been enrolled in a trial, sort of. You can put that up to SAIL, they anonymize it, and they might be able to give you back, these are the intervention, these are the controls, and then you have more group. Does that work with CPRD and other, as to how it works, following people up that you may have randomized, but it's identifiable data, this is now? Yeah,
so the idea of kind of directly recruiting people via CPRD data is, I think, I haven't done it on a trial that I've worked on, but I've kind of seen studies that have done it, and the logistics are I think it's quite complex, but it's essentially you would share with them a series of, let's say you're interested in people who we were just looking at a study with people with post-effective or post-acute infection syndrome, which is not kind of a thing that has a read code, but it involves a combination of potential codes and maybe treatment patterns. So we would send that to them and they'd run that search at their end. They would identify, I don't know, however many thousand, but then they send that list to the GPs, who obviously have access to that kind of personal information as part of their care, and they then invite people. And so you're not getting any of that personal data at your end. It's kind of via the GPs, and the GPs then send out invites from that list, and they may or may not want to kind of filter through that list at their end. That's one of the options you have. But I think in terms of the data flow, they won't send you all of the kind of personal identifiers. It's pseudonymized and then they re-pseudonymize. I don't know the exact technical details of how they do it, but there's a kind of slightly arm's length approach. But it is possible indirectly, obviously, to say, okay, we're interested in this group of people. Can you run the codes for us? And then can you facilitate directly inviting those people to take part in a trial? And maybe that's via SMS, so I'm not sure how the GPs do that. But yeah, there are options. But I think all of that then is kind of done, is integrated within their system, so they will then track those people, and you can go back after a couple of years and you kind of have those they create a linkage ID, etc. I know that Mike and Fiona are involved in Wales.
Oh, you've gone mute. You've muted yourself there.
Sorry. So Mike and Fiona were involved in some Welsh Government consultations where they were looking at I think public acceptability of maybe approaching people through registries or directly via health records in a similar way for trials. And I don't know where they got to with that Welsh Government. It was obviously a kind of thorny issue, depends on what kind of health conditions. When we had some consultation with our PAG group recently, people had been invited to trials for things that they didn't think conditions they didn't think they had. And so there's huge like trust and ethics issues. And yeah, people I think have now got a lot more access to their primary care records and don't always agree with what is in their GP notes and things like that. So I think you have to be really, really careful in this area. Like if you're inviting people.
We did have that experience in that somebody's wife wrote to us saying, my husband doesn't have the condition you've sent him a letter on.
Yeah.
And he did. So
okay. Well, yeah, even that is, people might not recognize that they have that. Well,
no, it's not that. It's not telling your partner or whatever.
Yeah, well, no, exactly. Exactly.
You're
like disclosure
entitled to. Yeah. So I think there's quite a bit of ethical questions around, not ethical, but more things you will need to work out what you're going to do.
Yes.
As people haven't volunteered to have letters sent to them.
Exactly. And just the tone of those letters. I think this person was saying it was very kind of, you've definitely got this condition and we're inviting you, and it wasn't clear who they could even talk to kind of query that.
Yes.
So a lot of a lot of potential issues. I think there's also options to, I think CPRD offer. You can do kind of dynamic recruitment where you do a wave of recruitment and then you're looking at the demographics of who we've recruited so far, and you might notice that you've underrepresented a certain group, and we can now adjust our recruitment strategy. So I think it's those. I think trials are a little bit behind with some of that, and it does seem like a massive missed opportunity.
So before we go, does anybody have any questions or thoughts of that they'd like to raise? Otherwise, I just want to invite people for our next webinar, which is the next one's in May, on the 8th of May, and will be on big data for complex diseases with text mining with Aaron Lacey, and about the a cardiac network with Libby Elvins. Yeah. And I think in the chat, if you want to book a place, the link is in the chat now, put out by Laura Morgan. So that's brilliant. Thank you so much, both of you. That was really, really, really enjoyable. Thanks very much.
Thank you for inviting us. Thank you.
Thank you. See ya.
Thank
Bye.
you.
Bye-bye.